An orthopedic evaluation or examination typically has three parts. The first being taking the patient's verbal history. The second being taking orthopedic baselines, which are range of motion, strength, possible nerve tension, and possible sensory testing or reflex testing, and possible functional baselines, such as the knee hurts when you do a squat, or the wrist is uncomfortable when you do a push-up, or getting down and off the floor is impossible. So a functional baseline, it gives us a better chance to look at what's relevant to the patient, and using it for cause and effect can be quite potent. Now, the third part of a typical orthopedic evaluation is testing, which is done either in the clinic or out of the clinic, for example, at an imaging center. Most orthopedic clinicians rely on orthopedic special tests and or imaging, sophisticated pictures of what's going on anatomy-wise inside the body. Now, I learned these orthopedic special tests in school, so do other clinicians. They can be found in lots of these tomes about orthopedic assessment. They even make little kind of cheat sheet books for how to access these quickly. I have not committed them all to memory anymore. I look them up as needed. But in contrast to that, I tend to focus on, or I do focus on, repeated movement testing. And that was something put forth by Robin McKenzie. Repeated movement testing is outlined in these 5 volumes of textbooks about how to use mechanical diagnosis and therapy. And so repeated movement testing involves moving the extremity joint and or the spinal joints repeatedly and assessing if that movement has an effect on those baselines that we took in part 2 and the symptoms that may or may not be present with the patient in the clinic. And the repeated movement testing is an algorithm that you have to learn and understand how to provide that type of testing. And it's focusing on physiology. If we move you this way, what happens? Certain diagnoses, for example, will not change when you repeatedly move the patient. For example, a fracture is not going to change if you repeatedly move the patient. A tendinopathy is not going to change, but a mechanically tweaked joint will. And that's what I find is what most people have, and they're being misdiagnosed as other diagnoses that typically focus on structures, right? Menisci, ligaments, labrums, muscle tears. Secondly, weakness and tightness, which just inexplicably seems to arrive. And thirdly, this bastion of orthopedic stories, such as IT band syndrome, that I don't think have diagnostic validity or criteria that you can really hang your hat on. So I'll use these orthopedic special tests as needed. And these are the ones that you might see on the field. For example, if a player goes down and you see a trainer or a clinician run over and kind of move the knee or move the ankle. We have, hundreds of these tests, everything from the ACL test, the Lockmans and the anterior drawer, to things for the wrist and the thumb and the neck and the back. We have tons of these tests, and some of them provide some utility, but I find most of them do not. And therefore, I choose to use repeated movement testing as the backbone of my orthopedic assessment as part 3, and that testing can continue at home. And I only rely on these tests when I really find them to be of value.